Thank you for the kind introduction. The title is meant to be more sarcastic than anything, to be honest. I think it's pretty fascinating that I'm not sure really most people know what we're doing when we're talking about this stuff. Um, and the media and everyone else and academics all come up with different terms for it. It was the overdose crisis, then the opioid crisis, then the toxic drug crisis. Is it actually just a mental health crisis or an addiction crisis? It's really hard to say what it is. These are my disclosure slide. It's really long, but I got in trouble once for going too fast on it. As mentioned, I'm with the Faculty of Medicine, University of Calgary, Department of Psychiatry and Surgery, and also with the Hotchkiss Brain Institute and the Matheson Center. I have some grants and research support over the last few years. I have done some work with Master Clinician Alliance, which is a not-for-profit, where I've done some speaking and built some programs. I did an unpaid Indivior National Advisory Board, and at CSAM, I moderated a lunch lecture on a large recovery data set out of the US. I am the chair of the Queen's Canadian Addiction Summit Conference called Ignite. I am the co-chair of the Western Canadian Addiction Forum, which I hope you can all make it to September 31st and June 1st in beautiful Kelowna, British Columbia. I also am the chairman for the Canadian Academy, or sorry, no, I sit on the co-chair for the conference for the Canadian Academy of Addiction Psychiatry, and I chair the Canadian Addiction Council. I've done lots of clinical development and building clinics, including here at the Rapid Access Addiction Medicine Program, where I spend almost the entirety of my clinical work. Not too long ago, it didn't even exist. And here we are as one of the country's largest outpatient addiction medicine programs. And I've done a lot of other work. Most of my pay comes from the Department of Psychiatry, University of Calgary through AHS in a academic ARP or salaried position. Really not any copyright issues here, I don't believe. I do come from the University of Calgary, or here in Calgary in Southern Alberta, and acknowledge Treaty 7, which includes the Blackfoot Confederacy, as well as District 5 and 6 of the Métis Nation here in here at the City of Calgary. So why are we here anyways? Well, I think we kind of know. Unfortunately, every day we're losing someone to a toxic overdose, an overdose, or what I like to talk about is we're losing people to addiction. And not everyone who is dying because of addiction. We're not really sure how many may have taken their own life intentionally. We're not really sure how many are accidental. We're not really sure how many are secondary to intentional use in the setting of an addiction. We are seeing a mental health crisis and an addiction crisis across our country. And honestly, I don't think there's an end in sight and no easy single answer. We see sound bites and political usage of terminology as selling, if we do this one thing, we'll fix it all. And we've heard that over and over and over again. And no one thing is going to fix it all. It is affecting us across this country. The worst and hardest hit is British Columbia, but we can see Alberta and Yukon also being hard hit by this. Why am I here? Well, I'm here because I want to make sure my family have a safe and good environment to grow up. And we can do everything we can as a family, but kids are going to experience everything outside of the home as well. I'm here because a year ago I lost my brother to addiction, and he died alone on the floor of a bathroom. About 2 years ago, I lost my best friend Tom. They're the two of them in the middle picture, who died of addiction, who died on his kitchen floor alone. About 2 years ago, I lost my best friend from childhood, Brent. who died I think he was in the basement at a house party, and also probably died of a unintentional toxic overdose. Um, that's why I'm here, because I've lost, and we talk all the time about people with lived experience and then told that physicians can't be that, but I've had a lot of experience and loss, and I've seen what addiction can do to a home and a family and a life. And I think that's why I'm really here. The question is addiction a disease? I hope that we can all agree on this part. Nora Volkow and colleagues have been working tremendously hard over the last several decades, showing the neurobiological aspect of the disease model of addiction. Addiction affects the brain. Addiction is a disease of the brain, no different than depression or obsessive compulsive disorder or Parkinson's or dementia. The definition of addiction can be really, really long, and I really don't like big, long definitions. So I prefer the 4 C's of addiction when we think about it. That's talking about having cravings, leading to a loss of control because of a compulsion to continue to follow suit with those cravings, leading to significant consequences. I think that clinically, that's how we look at addiction in most cases. A lot of people wonder, is substance use and addiction a voluntary behavior? Well, initially, in most cases, not in all cases, and we've all had situations where somebody was human trafficked and forced into substance use. But in most cases, uh, the use of a substance is voluntary. But it's the repeated use that we see changes in the brain. And those changes in the brain are areas that affect judgment and decision making and learning and memory and behavioral control. All of these become altered with continuous substance use. Initially, we use for a lot of reasons to feel good. You know, I've had a long day, I want to feel good. I'm going to have a drink, or I've had a long morning and I'm going to feel good. I'm going to have a coffee, maybe to feel better. You know, we know the number of university students using stimulants with sudden onset of ADHD are pretty high, and many of those people are using stimulants to do better, to feel better. You know, how can we blame someone who have been struggling with you know, their own mental health for the first time they use a substance and they feel normal? And I've heard that so many times from people, that the first time I you know, used cocaine was the first time I didn't care what everybody was thinking about me, that I got out of my head, that I felt normal. The first time that I used an opioid was the first time I felt loved, the first time I felt normal. The first time I got intoxicated on alcohol was the first time I felt relaxed, I felt normal. We see so many people self-medicating to feel normal, to feel okay. And then we judge them for that. I don't really grasp how we can do that. Um, and many of my patients have told me it's the first time they felt normal. Freud used to give everyone cocaine. He believed that cocaine was the answer to mental illness. Maybe if he gave everyone mushrooms, he would have been better off with his theories. But at that time, he really believed that was going to be the answer. He learned that it didn't work. But initially, everyone feels better on cocaine. Everybody can feel better on alcohol or on substances. Long term, they have deleterious or negative effects, worsening mental illness. People use voluntarily for curiosity. Their social group is using, they're going to use. The data is unequivocal about that. There is some data showing your social group has more influence on you than your family. So, you know, because others are doing it is huge. So access to substances is a major part of this. And you know, we know that we've seen more and more access to more and more substances, which is going to lead to more and more addiction to those who are vulnerable. And perfect example, at one time in addiction medicine, we used to treat a lot of people with addiction to barbiturates. I'm going to assume that the vast majority of people here are not treating anyone with a barbiturate use disorder because there's no barbiturates. Now, I do have the odd patient here and there that's ordering them online and able to get them, but access has really been extremely limited. So we see very little people suffering with that. It's that repeated use. So susceptible individuals with repeated use, you get that initial positive effect that eventually starts to go away. You're feeling normal. Over time, you build tolerance. Problems and consequences start to develop. Those physical, emotional, social, occupational, and legal problems start to develop. Then we start shifting from substance use to addiction. Now, I want to be very clear. We're not here to talk about people who use drugs because in human societies, all societies have humans that use drugs. There has been one society in all of history that did not use psychoactive substances, and that's because on the island of that society, there were no psychoactive substances. So if they're available, we as humans will likely use them and engage them in either spiritual reasons, religious reasons, recreational reasons, or psychiatric or mental health reasons. Uh, Substances are there and people use drugs. I am currently drinking a Starbucks coffee. That's not a plug for Starbucks, and I have no shares in it, but it has very high caffeine, so that's probably why I prefer it. Now, we look at what is susceptibility. Well, susceptibility often comes from adverse childhood experiences. Now, I really, really want to challenge everyone, this kind of call to arms or call to action. We should probably stop calling it an experience and probably call it a trauma. But an ACT doesn't sound as good as an ACE, so it's going to be tough to change that. But these are not just experiences, these are traumas. And these traumatic events can have negative, long lasting effects on health and well being. Now, there's three types of ACEs. There's the physical, emotional, and sexual abuses. There's neglect, physical and emotional neglect, and then the household dysfunction. So mental illness in the home, drug use in the home, or substance use in the home. Uh, Witnessing your mother treated violently, divorce, and someone incarcerated, a first relative in the home being incarcerated. So these are ACEs, or adverse childhood experiences, or quite simply traumas of childhood. Now, about 1/8 of the population have 4 or more adverse childhood traumas, but about 2/3 of our population have had at least one. Most of us have experienced a childhood trauma of some sort. When you hit 4 or more of these, this is when the risk factors significantly increase. There's a 3 times, not 3%, 3 times increase in the levels of lung disease and adult smoking, 11 times increase in the level of IV drug users, 14 times the number of suicide attempts, 4 times more likely to have begun intercourse at an early age, 4.5 times more likely to develop depression, 2 times the level of liver disease. Quite simply, they affect all aspects of our life, from brain injuries and other fractures and injuries to mental illness, all the way down to occupation, education, income, and quite simply, most importantly, longevity of life. People with 4 or more adverse childhood traumas are more likely to die at an early age. So when we think about the pyramid of addiction, we often think about that genetic predisposition. So that's really important. If I'm exposed to an opioid, I get dizzy and sick, and I feel really quite terrible. Someone else might feel quite euphoric. Some people get a lot of energy. Some people get no energy. They're very different. So the way you genetically respond to the substance is huge. Those adverse childhood traumas are huge. Then there's that development of personality and coping skills, emotion regulation, addictive behaviors, and addiction. Most of our work in a treatment is focused on the coping skills and the emotion regulation. Now, we all have a toolbox of skills. Some people have way more skills than others, but we all have some skills. Substance use disorder or addiction is often the replacement of those skills for a substance because, quite simply, that substance worked better the first time you used it. And then it's the continuation of that substance that leads to not many other skills. And so what do? We detox somebody. We take them off their substances and say those are bad. We like to call things good and bad. So we say that's bad. You got to stop doing it. Except their toolbox is empty. And the reality is they're still going to have stress. They're going to struggle. They're still going to have to deal with stressors in their life. They're going to be triggered by some traumas in life. And they're going to have these thoughts of, what do I do? I don't know how to cope with this. I'm feeling overwhelmed. I got this little voice. Maybe it's my doctor's voice or my therapist's voice or my family's voice or my friend's voice. Don't use, don't do it. That's bad. But my toolbox is empty. So what do? I go back to doing what I know works, except that perpetuates significant shame and guilt, often leading to significant relapse. And I know we don't like to use the term relapse, but I actually find it to be quite an educational term. Relapse is an opportunity at treatment. It's not a negative thing. It's a chance to really get back into treatment and figure out what happened and how do we prevent that from happening again. Of course, in treatment, not only do you feel shame when you kind of end up using when you're trying not to use, but we in the therapeutic and the treatment world can perpetuate shame. When we're talking about adverse childhood traumas, we can perpetuate shame. We can trigger traumas. So we really need to build that relationship. We need to be non-judgmental. We need to be mindful and be in the present and be very aware that a lot of people who have struggled with childhood traumas and with shame and addiction are often much more sensitive to how we're responding to them. A big part of treatment is building resilience. Now, what is resilience? A lot of people think this is resilience. Now, if you're old enough to know what that is, great. If you're not, that's not my fault. But we kind of all grew up with this thing. This was bozo. You would hit it, it would fall over, come back up, the blow up clown. And we often think this is resilience, being able to get up from a punch all the time. This is not resilience. Resilience is actually the rodeo clown, the ability to avoid the punch in the first place. That is what resilience is. So it's about not just withstanding the loss, but preventing the loss in the first place, recovering from a loss. It's also how much the system can absorb, the magnitude of shock it can take, the capability of self-organization, and the ability to build capacity for learning and adaptation. That is resilience. So when we think of resiliency, and I love to use the Alberta Family Wellness Initiative slides for this, and it's noted there as well. I love this kind of negative experiences and positive supports, the fulcrum. So we look at them balancing and we look at having more positive supports than negative experiences means that you are more resilient. We're shifting the fulcrum towards a positive outcome. But if you have more negative experiences than positive supports, we shift that fulcrum towards less resiliency, leading to more negative outcomes. But we can actually focus on this in treatment. So we can add positive supports, that's skills. Those are communities of health and wellness supports, AA sponsors. All of these kind of things are important in the positive supports. We can also reduce the negative experiences. It seems crazy. Well, I had a negative experience. How do you reduce it? Well, trauma-focused therapy can reduce the effect of that negative experience. It can reduce the effect of childhood trauma. And this is really important. In the rest of the world, we have something called complex PTSD. This is a diagnosis used by the International Classification of Diseases 11. In North America, we use the DSM-5, or now the DSM-5-TR. It does not include the diagnosis of complex PTSD. Complex PTSD is often interrelated with childhood trauma, not all the time, but often. And that means that if there's a diagnosis, there must be a treatment. The data clearly shows that by using trauma-focused therapy like EMDR or cognitive processing therapy or prolonged exposure, that we can actually treat complex PTSD. In Canada and the United States, we often call this borderline personality disorder, or we call it addiction, or we call it treatment-resistant depression, treatment-resistant anxiety. We don't actually go back to labeling those traumas as a part of the diagnosis. We often call those adverse childhood traumas risk factors, and we're not actively treating it. But if we treat the traumas, and then we add the 12 steps, and we add cognitive behavioral therapy, and we add all these other focused therapies, we can reduce the negative experiences to shift that fulcrum towards more resiliency and better positive outcomes. Now, again, we are distinguishing addiction from people who use drugs. These are a huge Venn diagram overlap, but our focus is on substance use disorders. When we start looking at our most vulnerable in society, we're often talking about those individuals who are unsheltered. BC's got some great data, recently some great published data out of Edmonton as well, but in BC, it's expected about 1,650 of the about 8,700 individuals living without home, 1,650 were unsheltered, meaning they're sleeping outside. This is about a 11.5% increase since 2018. These are massive increases that we're seeing year over year. What we're seeing is that about 1 in 3 have a reported acquired brain injury. 2 in 3 have 2 or more health concerns of some sort. We know the vast majority of these people are struggling. We know the risk of those individuals are very high of having a traumatic brain injury. In 2 studies, one in Vancouver, one in Toronto, about 1 in 2 individuals have some sort of traumatic brain injury. But more importantly, is that approximately 1 in 4 to 1 in 5 individuals have a moderate to severe traumatic brain injury, living unsheltered, and somehow being resilient enough to survive on the street. Now, for you and I, who may be privileged enough to have a shelter and a job, sorry, I just lost my apologies. There we go. We would probably require significant supports. We would require help just to live day to day. These are individuals with no supports, living with severe brain injuries. We see increased substance use disorders. That's such a spectrum in the data, anywhere from 30% to 90%, depending on what you read and who you're talking to. Huge amounts of chronic pain and much higher prevalences of mental illness. So where do these people that are struggling end up getting brain injuries? The majority are coming from assaults, and lesser so from overdoses. And so we know that as that crisis continues with overdoses, we're going to see more and more individuals with brain injuries. Now, when we're talking about people who are unsheltered and overdoses, the vast majority of people over the years who have died from an overdose have died in a home or private residence of some sort. This is dramatically shifting over the last year or so, where we're seeing in Q3 of 2023, 53% of overdoses occurred in public on the street, only 25% in a private residence. This is a major shift. Now, there's a lot of ways that we can look at it. Is it because those who are living in a home know how to access the resources? We've seen a significant increase in resources for addiction treatment in Alberta. Are they getting help? Maybe, maybe not. Maybe the housing crisis has crunched us that more and more people are ending up on the street and our homeless numbers are different. There's a lot of variables here that we're not sure of, but what we are sure of is that that increase in overdoses and deaths are occurring on the streets and in public. This is a major issue. We're going to talk a bit about drug policy. Now, of course, if we talk about drug policy, we must talk about Portugal because that's what everyone does. So let's look at Portugal and the radical drug policy that was working in Portugal. Now, it was a 5-pillared approach. We have 4-pillared in Canada, 5-pillared approach. So one was prevention. We need to prevent substance use disorders in the first place. We need to prevent the use of drugs. That meant increase in enforcement, increase in the prevention of substances from getting into Portugal in the first place. Harm reduction. We need to reduce the harm of substances, but most importantly, reduce the harm of those people with a health disorder. That was a part of decriminalization. We'll come to that. Then there was treatment, and treatment was often through a dissuasion panel, which included a psychiatrist, social worker, and community member. And they determined whether or not, if you were caught openly using substances, you would end up with a dissuasion panel. They would decide, do you have a substance use disorder or not? If you do, you're offered treatment. If you refuse it, you're offered a fine. Many of that led into the treatment algorithms. And then, of course, from treatment led to reintegration into society. Now, it's important to understand that all of this was important. The decriminalization of drug use was just one component of a comprehensive drug policy. We can't just pick one piece out of this and say, there's your answer. That's exactly how we fail in drug policy. But rather, it was an entire approach looking at all aspects. Now, it's also important to understand that decriminalization in Portugal was not about decriminalizing open drug use. It was not about decriminalizing behaviors that come with intoxication and substance use. It was about decriminalizing personal possession of small amounts of drugs, so that we were no longer criminalizing the health disorder of addiction, but rather shifting it into the health focus and out of the criminal justice focus. The concept was a coordinated structure right from the Minister of Health, a national coordinator, and then to the National Council and interministerial councils. There was technical commissions. There was then the thematic subcommittees. There was all the way down to the individual treatment provider. The entire system changed. That's what we call a recovery-oriented system of care. Now, in Alberta, we've moved towards the use of a recovery-oriented system of care. And a lot of people like to call it the Alberta model, but let's be clear. It was first published by SAMHSA in 2010. It was endorsed by the CCSA, the Canadian Centre for Substance Use and Addiction, in 2017, that all provinces should be doing this. Alberta just happens to be the first province doing it, where our Minister of Addiction and Mental Health now trumps all other ministers when it comes to integrating this recovery-oriented system of care. No longer is addiction and mental health basically an appendix in health policy, and even more so an afterthought in healthcare budgets, but rather a prominent and upfront area that not only is being highly funded, but now has leadership right from the very top. So we talked a bit about treatment, but most importantly is access. We need voluntary treatment that is accessible on demand. So to give you an idea, that means if I'm in the hospital and it's determined I have a substance use disorder, I should be initiated on opioid agonist treatment. If I'm in the emergency department, I should be initiated on opioid agonist treatment. If I'm in front of my primary care physician, I should be initiated on opioid agonist treatment. If I just decide I need help, I should be able to pick up a phone and be started on opioid agonist treatment. And that's what the VODP is doing. We have, for the first province, and I still believe the only jurisdiction in North America, where all of our emergency departments have been trained on opioid agonist treatment and initiation of buprenorphine naloxone. We have to have access to some of the harm reduction mechanisms. That includes our supervised consumption services. And per capita, we're one of the highest in the world for supervised consumption services. Both DOORS and NORS, these overdose virtual response services, are extremely important. In Calgary, where I'm at, we have the Rapid Access Addiction Medicine Program, where you can be seen by addiction medicine, by counseling, on demand as needed. We have psychiatry, we have trauma-focused therapy, and referral sources into mental health if required, and direct access into referring to inpatient treatment. But we also have intensive outpatient programming, mindfulness, relapse prevention, all these other programs. So the RAM right now with adult addictions is about 30 counselors, 15 doctors, psychiatry, trauma therapists, all available from a walk-in to an emergency department. to primary care referrals, taking referrals from all aspects. This is the concept that needs to be available to all people throughout the country. What is the best evidence of reducing death from opioid use disorder? This is probably one of the most prevalent studies out of Boston, kind of the mecca, academic mecca or academic center of North America. What they found, if we detox someone off of opioids, whether heroin or fentanyl or whatever, the risk of death is extremely high. We can reduce that risk of death by about 37% if they go into inpatient residential treatment. We can further reduce that risk of death by 66% by adding a medication for opioid use disorder or opioid agonist therapy like buprenorphine, naloxone, or methadone. We can further reduce the risk of death by combining residential treatment with medications for opioid use disorder, where we can reduce that risk by 89%. There is nothing that has shown reductions in death as comparable to that. And we can see that this has been studied over and over. Buprenorphine, reducing in overdoses and hospitalization or emergency visits by 90%, methadone 88%, naltrexone 86%. Reduction in overall overdose deaths by 62% just by initiating buprenorphine after a non-fatal opioid overdose. So we do not see those reductions, and this isn't cherry picking data. This is looking at overall data sets and seeing incredible reductions in overdoses by evidence-based treatments that are the gold standard in our guidelines. Now, why isn't this available to everyone? Why don't we have voluntary treatment free with access on demand to all Canadians? Well, it's a pretty simple answer. It's not covered in the Canada Health Act. So although I am covered as a physician, I can write your prescription. That's usually covered through different ways. Under the Canada Health Act, seeing the addiction counselor, the social worker, the psychologist, the occupational therapist, physiotherapist, quite simply, chronic complex illness is not covered under the Canada Health Act. So now it's just up to the provinces, and every province can decide how to approach this because it's not mandated legislatively. Hence why we have so much private and public, and it's a mishmash of everything, and why it's not available to everyone. A recent CIHI study simply said we need to rethink the Canada Health Act, that other countries that include mental health and addiction as part of their universal system have better outcomes, better access, and we need to step up. And it's up to us as Canadians to decide that yes, the most vulnerable deserve the same service as when I twist my ankle and go to emerge. Now, Safe Supply is another treatment that's being used. It is an experimental treatment. Regardless, there is some data that shows it reduces the use of the healthcare system by being connected to a Safe Supply program. There is no data like what we just finished talking about it, of reducing overdose deaths when looking at actual data sets without creating our own controls. And of course, the big concern around Safe Supply is diversion. We have to be very clear. The way we ended up in this crisis of opioids, which was initially mostly OxyContin, was the prescribing of opioids in the first place. And that prescribing wasn't that the people who were taking the prescription as prescribed were causing problems. It was the people who were diverting it and others getting the access to it. As we talked about, more access, more use, more risk of substance use disorders. And now in the world of fentanyl and its analogs, this is non-pharmacological fentanyl and analogs, that risk of death is extremely high, even though it was high before. Now, this is an experimental treatment. It's being studied and we're reviewing it. And Safe Supply isn't about the molecule. This isn't about hydromorphone, right? Hydromorphone to somebody who's using high dose fentanyl is kind of like giving someone a Tylenol 3 who's on high dose oxycodone. It's not going to do anything. We simply can't use a molecule that can't keep up with the potency of another molecule and rotate them that way. The molecule itself isn't the problem, whether it's heroin or fentanyl or methadone or hydromorphone or buprenorphine or Cadian morphine. The molecule isn't the problem, it's the practice that we're seeing. And the idea that diversion isn't real or that it doesn't matter or that it's not causing harm, it is the reason we got here in the first place and the reason so many experts around the country who have been working in addiction for so many years are saying this isn't the right approach to it, although it's an experimental approach and we need the data. When we look at evidence-based guidelines, the first line treatment for opioid use disorder is an opioid agonist treatment. Now, the plus and minus psychosocial is probably going to change. It's going to say plus psychosocial if available, and plus or minus residential is, again, if available. First line is buprenorphine, second line is methadone, third line is Cadian or slow release oral morphine. That is what our guidelines say. Now, that doesn't mean that we don't use harm reduction. Harm reduction approaches are part of our guidelines. They're extremely important. And that includes safer use of sterile syringes and needles and other applicable substance use equipment, access to sterile syringes, needles, and other supplies, access to take-home naloxone kits, and access to supervised consumption services. The most updated opioid use disorder guidelines were put together by the BCCSU and published in 2023. In there, the quality of evidence for harm reduction was moderate, the strength of recommendation was strong, but it did not include safer supply programs because that is an emerging program, a novel approach, an experiment that we're looking at. And when we're looking at developing drug policy, we don't start with experiments, we start with the gold standard first-line treatments. And those treatments need to be voluntarily available, free, on demand. I need help immediately, strike while the iron's hot, all of those kind of things. We need that immediately. And that is extremely important when we're looking at access points and helping individuals. Now, we're going to shift into some controversy. That controversy, which we're going to really question how controversial it is mandated treatment. Now, mandated treatment has significant precedents all over the world. Whether we're talking about Massachusetts, again, the academic hub of North America, or we're talking about Australia, or we're talking about New Zealand, we're talking about countries around the world who have incorporated these kind of programs. But what does it even mean? Well, first of all, do we think we should have it? Well, it turns out in an Angus Reid Institute poll done in 2019, the vast majority of Canadians highly support, strong in favor, compulsory treatment programs. More Canadians support that than supervised injection sites or decriminalization. And what's really fascinating, it doesn't matter if you're conservative or liberal or NDP or if your colors are pink or purple or green or red or orange or whatever color it happens to be. In fact, when you look at the political sphere, liberals were more likely to support it, followed by NDP, and last was the Conservatives. 85% of Canadians supported this. And suddenly we've seen a bit of a shift. It's amazing what the media can do because since 2019, there have been no new studies other than this one. And this one was just published in the Canadian Journal of Addiction. It is open org, so anybody can read it. There's no firewalls. You don't have to pay for it. And this is the largest study ever done. It was commissioned by the Canadian Society of Addiction Medicine under their policy committee where I sit on, led by Dr. Anis Baji, a addiction psychiatrist here in Calgary who's under his PhD program right now. We reviewed 42 studies with over 350,000 participants. So the former study done by WERB was like 9 studies. This is 42. No studies compared involuntary treatment to no treatment. That's one of the major weaknesses that we can come up with. So we're talking about voluntary versus involuntary. And what we found is in some cases, voluntary treatment was better than involuntary. The person saying, I want help, did better than the person who was told to stay out of jail, you better do this. In some cases, the person told to stay out of jail did better than the person saying, I want help. And in some cases, there was no difference. And in fact, in reviewing all of the data, there was a lack of high quality evidence to support or refute involuntary treatment for substance use disorder. It absolutely, in the most sophisticated, systematic review of all the data all over the world, we could not decide whether or not it was beneficial. What we did find is that programs that had good mental health supports and followed evidence based treatments often did better than programs that didn't even tell us what they were doing. Importantly, can we keep doing nothing? We know that a substance use disorder is a mental illness. We know it's a health disorder. We know with other people who are struggling with mental illness, to give you an idea, somebody who decides, I want to end my life, we would never allow that to happen. Somebody on a bridge, we're going to have people running to help. We're going to have EMS there. We're going to bring them to hospital. We're going to sometimes involuntarily treat them in hospital with different mental health act forms. But if that same person wanted to inject a lethal dose of fentanyl, we probably wouldn't do anything. So you can't tell me that this isn't stigma, that this isn't discrimination. In fact, in some cases, this is just pure racism. And we start looking at the data. In Alberta, if you present to the emergency department for a substance use disorder, about 1 in 10 individuals will have died in 1 year. If you present 4 times or more, about 1 in 6 individuals will have died within 1 year of presenting. Because really, when you present to the emergency department, we do a whole lot of nothing. We may initiate you on OAT, which is great, but otherwise, not much else. We start looking at individuals who are presenting. Literally thousands, 29,000 people presented to an emergency department last year in 2022, because of a substance use disorder. One person presented over 20,000 times, 20,000 people presented once. One person presented over 156 times. 156 times they came to the emergency department for help. Another person 87 times, another person 76 times. 2 people presented 72 times, one person 60 times. And we've done nothing. One person took an EMS to hospital 112 times to the emergency department for a substance use disorder. Another 80 times, another 49 times. We are seeing people over and over and over again coming to hospital for help, and we're doing nothing. How long do we do nothing? Because mandated treatment isn't this. It isn't detoxing on the floor of a prison. That is not what mandatory treatment is. Maybe mandatory treatment is following up with your addiction counselor once a week in an outpatient environment. Maybe it's taking a medication that is shown to reduce your risk of death. Maybe it's inpatient. We don't know. Maybe it's intensive supports like housing, like education, like job training. We don't know. But what if that's what we're talking about? What if we're talking about helping people get into recovery housing afterwards? And that's a part of their treatment. This is Westman Village in Mahogany. I mean, honestly, it's really, really cool. It's for those who haven't been there, it's basically 3 buildings in kind of a T intersection that you drive into. The middle is your village center. It's got a pool and a water slide and a movie theater and a library and conference rooms. And then along the rest of it are apartment buildings with little stores everywhere. Imagine if this is what recovery housing looked like, where everybody here was recovering and working together, where there were AA groups and smart recovery groups and Dharma recovery groups happening at the village center, where stigma was removed and being in recovery was not only acceptable, but it was celebrated. Celebrated like ringing the bell when you're leaving the cancer center. So it could be outpatient, it could be medications, it could be housing, it could be intensive treatment. We don't really know what it is, but any of those sound better than doing nothing. And the question is, what is recovery? Well, it's very individual, it's very personal. I look at treatment and recovery as a spectrum, starting from harm reduction on one side, reducing the harm of substance use, moving into treatment and the possibility of abstinence from substance use. But maybe it's abstinence from the sex trade. Maybe it's getting a home and no longer living homeless. Recovery is a spectrum of so many different areas. It's individual, and it's up to us as providers to work with the individual to find out what it is. And we can do so much better than nothing. And most of our most vulnerable people deserve so much better than what they can get in Canada. And I leave you with this. This is from Keith Humphreys, professor at Stanford, lead of the Stanford Lancet Commission, really the well-known lead of publications in addiction, maybe three of them, David Best and a few others, John Kelly. He's the senior policy analyst at the White House, worked under both Obama and Biden and Bush. And here's an individual who said it best: leaving Canadians who are addicted to die on the streets from drug overdose is not compassionate. And I would finish it with, it's not Canadian. And I'll leave it at that. And that should give us quite a bit of time for questions, answers, or opinions anyways. Of course, I have pretty thick skin, so if you want to yell at me, I can handle that too.
Thank you so much, Rob. That was an amazing and thought-provoking presentation. I know we had a couple of questions in the chat, so I'm going to pass it over to Tracy and Crystal, and then we can take some live questions that you may have.
Actually, we haven't gotten any questions in our chat yet. So if
no.
anybody would like to put
No,
your question.
Oh.
If you'd like to put your questions in the chat, that would be helpful.
Well, there is one. There is one. It's Dr. Tanguay. What are your thoughts on utilizing ketamine or iboga in therapeutic settings to
that must have went straight to you, Robert.
Craving and the addiction cycle.
Yeah, I mean, again, experimental. I think that quite simply what we're seeing with the use of ketamine or psychedelics, ibogaine is really, really dangerous in opioids, mostly because it removes all the withdrawal symptoms to help someone detox. But if you're not actually getting any support afterwards, the risk of relapse is high. And, unfortunately, in this day and age, that risk also leads to a really high risk of death because your tolerance is gone. And we've seen it in our opioid clinics here in Alberta. Many people would head off to BC and would do an ibogaine and come back and say, I'm off of everything. And the outcomes are unknown. So, but as for the rest of it, absolutely. What we're usually doing is treating the underlying mental illness, maybe getting right to the root core of the reason of the addiction in the first place. But these are experimental. And when we think of drug policy, the first thing we need to do is have free, on-demand access to evidence-based gold standard treatments. From there, we're going to have people that don't respond to treatments, and we work our way down to different levels of treatment. No different if you're going for cancer and you start cancer treatment with a first-line evidence-based chemotherapeutic agent and other agents. And if it's not responding, you start working your way down to experimental. This is what good health policy looks like. And for the life of me, I can't believe that there's arguments about whether or not we should be spending money on treatment. We would never argue that about cancer. We'd never argue about heart disease, yet we know not everyone's going to survive cancer. Not everyone's going to survive heart disease, but that doesn't mean we don't do everything in our power to save that person. It's mind-boggling to me that we can't all agree on the same thing for people who are suffering with addiction. That was a very long answer.
Thanks, Rob. We have another one. Can you think of a way to deal with the poison drug supply other than the government regulating drug production and drug distribution?
Yeah, that's a great question. Look, I'm going to give you another opinion. So I think the concept of safe supply makes all the sense in the world. The folly with it is the harms that diverting opioids such as hydromorphone, which is not an inert substance, it's a really potent opioid, to naive individuals. And we're seeing more and more anecdotal. It's anecdotal evidence, but the whole thing is anecdotal, anyways, from the treatment itself to the outcomes that people are concerned about. Is that there is diversion occurring? That part is anecdotal in this population, but the overwhelming knowledge of diversion is led to billion-dollar lawsuits that Purdue has been paying off. That's pretty good evidence. So I think that's the big risk. So how do we do it to prevent the diversion? What if we offered fentanyl and heroin and hydromorphone and anything else inside of our supervised consumption services, where access is there, it's prescribed, you can't leave with it, and you can't die? Now you remove the criminal element, you remove the issues of not being connected to the healthcare system. Suddenly, harm reduction becomes an entry point to treatment and supports the access points. In my opinion, that's how I would go. But I know a lot of people disagree with me on all sides of many spectrums. So, but I really think that we have these incredible services. Why not utilize them? Why not medicalize them? Why not actually have experts working in it?
Thank you so much for your energy and passion in this, Rob. Any extra comments about methamphetamine? Another question.
Yeah, it's one of the hardest ones to get to. Look, we've got contingency management. We've got the new stimulant and amphetamine guidelines out of the American Board of Addiction Medicine out of the US. And quite simply, it's saying, try this and then try this and then try this and then try this, because medications have shown over and over again that they don't have very much benefit. Kind of that first line is that naloxone or naltrexone combined with bupropion or Wellbutrin at higher doses. You know, in my experience, it's worked for some, it hasn't worked for others. The best treatment for this is inpatient treatment in most cases. But if we can get good contingency management, working with individuals in the community, the problem is nobody's just using one substance anymore, right? We used to have individuals using meth and then individuals using heroin and then like that, it's all across everything now. And so it's a really, really hard piece where we don't have the same data for kind of medications for opioid use disorder. We have excellent outcome data from methadone and buprenorphine. We don't see the same in methamphetamine. Now, there is the Optima 2 trial happening here in Canada where they're using high-dose Vyvanse or lisdexamphetamine. My concern, it's a pro drug, so you can't really get to the high peak levels that you need. And we'll see. Maybe the data does show that it's going to work, and that would be a win. But we haven't found anything that really works outside of really, really good psychosocial treatments.
Okay. You go ahead, Tracy.
Yeah, I have a question. I think that a lot of us experience, which is about our clients are often mistreated in hospitals and in clinics. And what would you recommend for changing the attitudes of those in the healthcare field or, just in general, so that clients can get the care that they need?
Well, I think the first thing is everybody should go through mandated addiction training. If you're a healthcare provider, you should be getting the training and learning from people who actually care. Look, we can blame the emergency departments, but they're burnt out and overwhelmed. Our last data set showed about 60% of individuals admitted to hospital and waiting for a bed in the emergency department, sitting in the emergency department, waiting for better mental health patients. In my opinion, mental health and addiction needs to come out of the hospital. It needs to be accessible. We need to have centers throughout our country that are easy to get into, easy to access, that are beautiful, that don't, you look at a hospital like Foothills. Foothills is a huge hospital in Calgary. The entire emergency department was completely revamped and renovated, with the exception of our mental health beds. There it is. It needs to be taken out. It needs to have the right people there working with it. We can learn so much from people working in harm reduction about how we approach patients and how we work with patients, the kindness and compassion. But we can do that with boundaries and with treatment. As they say, meet people where they are, but don't leave them there. And we've got to include having more accessible points in the community. Primary care physicians have to do rotations. I literally talk to primary care residents, and they tell me their preceptor stigmatizes patients when they come in. Oh no, it's this one. Oh no, we got to do this. We've got to change it right from the ground up, and we've got to put it on Royal College and college exams. If you're writing your exam in psychology and social work and medicine, in nursing, it should have addiction on the exam. So you have to learn how to do it, and you have to learn how to do it right. And even then, that may not remove all the stigma, but maybe that starts in perpetuating an open and non-judgmental environment.
Yeah, another question we got is chronic complex illness covered at all by Alberta Healthcare? And if it is, how or what methods are there to convince people they are in the need of it and when they are at the precipice of their substance use? We see.
Yeah, sorry, go ahead.
There's one more sentence. Sorry, Rob. We see multiple people from our first responder veteran community who are resistant to supports when they are struggling with addictions and substance use.
Well, that's like a super loaded question with 3 or 4 different types of answers. So let's start with the first part, chronic complex illness. Yes, every province funds it. It's just not mandated under a Canada Health Act. So the funding is usually quite secondary. But, in Alberta, we have the U of A pain clinic, the chronic pain center in Calgary. We have the RAM clinic here. We have all of our inpatient residential treatment centers. There's diabetes clinics. There's things like Counseling Alberta. The CMHA has. There's so many that are funded. It's really, though, it's so intra-provincial. It's not federal. It's not mandated. It's not a part of our healthcare policy. If somebody can't get help and emerge, it's front page news. If somebody can't get help with their addiction, nobody talks about it. And that's, again, just the pure discrimination in our media and in our society as a whole. First responders, veterans. Yeah, I mean, we can start with veterans. There are so many programs that veterans are approved to go to. The problem is trying to get into it I mean, it's a circus. You got to cross hoops and barriers and obstacles. It should be easy and it should be free for them to get into. And those programs exist. Veterans can access our inpatient treatment centers like Ravensview and Edgewood for free. But they need their case managers. They got to go to the Legion. The Legion's got to help them connect with the case manager. They've tried to reduce this by saying, it's basically you have this disorder until proven otherwise, and we can get that treatment. But now it's been a bit of a runaround. We see some of our great housing initiatives that are waiting a year to get a psychiatric assessment. How is that possible? It just doesn't make any sense, and we've got to utilize some of our community and not focus on we'll use the OSI and nothing else. There are many programs that have been approved by VAC to allow treatment. It makes no sense. First responders, we've seen some of the great work by groups like Wounded Warriors. The Newly Institute is doing a lot of work here, and yes, I have a bias there and a conflict, but there are great programs, and these outcomes are being measured and utilized and we're seeing really, really good outcomes. But again, you know, traditionally a first responder struggles, they go to PTSD treatment and they're sent into a physiotherapy clinic and thrown on a treadmill. It made no sense. Now we're seeing programs that are built from the ground up by experts treating PTSD, addressing the moral injuries, addressing the anger, addressing the injustice. Those Alberta has great access. BC has access. We're seeing legislation. So, you know, it's basically you have PTSD until proven otherwise if you're a first responder. Most of our provinces, not all, and some of them are now spreading into healthcare workers like nurses and frontline staff, not all of them. But we're seeing the shift. But, you know, we're talking about transformational change in a society, and that takes time. And but I think the political will is there across the board for, you know, our real heroes, and that's our first responders out there. I have a question that was sent to me directly. It seems like there are a lot of pharmaceutical options to deal with substance use. What do we know about effectiveness and accessibility of treatments for underlying complex trauma? If that is really the issue that needs to be addressed. Okay, Geary just set me up here. Look, you know, quite simply, you know, the treatment for complex PTSD is similar as the treatment for PTSD. The real world data for treating PTSD is about 1/3 of individuals get better, 1/3 of individuals get nothing, and 1/3 of individuals get worse. This is why we need to figure out how to do this and do this right. There is good data, actual trials treating complex PTSD with EMDR, with intensive EMDR, and the outcomes are great. Most of those individuals in Canada would be referred to a DBT program where they're suffering and forced to sit in group for a year or two before they even approach doing the trauma-focused therapy. We need to do this the other way. We really need to focus on treating the trauma, and then for those who need it afterwards, let's do some skill work. But it's a complex process. But absolutely, the data is there. The accessibility is a whole different topic. It is very difficult to get access to trauma-focused therapy. It was part of what we wanted to do here at RAM. But even opening RAM here in Calgary, we had to go around AHS and do it by applying directly to AH and ministry. And then when we got it approved, come back down and work our way up. Anyways, it's ridiculous. So the reality is you need a lot of foresight. You need to think about, if we're treating addiction, we need to have mental health services, psychiatric services, trauma services intermixed with it. And unfortunately, that is really not accessible around most of Alberta and most of Canada.
I'm going to give the CSP Learning Center a chance to chime in. They haven't had access to the chat, so.
I do have one question here.
Oh, you do?
From someone at CSP, and then, yeah, we can definitely take live questions.
Okay.
So there's a strong not in my backyard sentiment for neighborhoods and surrounding businesses of safe injection sites. For example, there was an article in the Sheldon Schumer safe injection site that interviewed businesses that felt overwhelmed by the issues that can come with being near these treatment sites. For example, needle collection around their businesses. Do you have any insights on how the government can help businesses or neighbors who need extra help or need to offer extra help?
Yeah, so I find NIMBYism to be also a very stigmatizing term, because I think it's also called human nature. You know, I think everybody has some NIMBYism in them, no matter who you are. But removing that term, in my opinion, we need more, A, and we need to medicalize them, B. So if we had more of them, we wouldn't centralize the process. We've seen the harms of centralizing a single or one or two of these programs, especially when there's no physicians working in them, there's no treatment available in them, there's no mental health services available in them. And the second part, when you centralize, well, of course, people need to purchase these substances in order to purchase them. If they're not working and they don't have access to money, they know how to get money. And that may be through the sex trade, that may be through crime and stealing. So we simply need to prescribe it. If it's prescribed, there's no cost. You're now starting a treatment algorithm. You're connected to experts. You're working your way through processes. You start building hope. And right now, imagine going to a center where you're told treatment doesn't work. We don't need to spend money on treatment. It's not really going to do you any good. How much hope are you going to have? This is the best I got, is to come into this center and use my drugs, and then go out there and do whatever I have to do to get the money, to get the drugs, to come back in here and to use my drugs. It's horrific. So in my opinion, if the substances are prescribed and we have more of these programs available, then we'll have less of the elements that a lot of people are struggling with. Whether it's open drug use or criminal behavior or whatever the case may be. And then, of course, we need to fix our criminal justice and health systems to interlink together. If we did it like we did in Portugal, open drug use and open intoxication wouldn't be tolerated. And quite simply, nobody would be complaining.
So wonderful answer, Robin. I really appreciate the depth of the answers that you have. We're kind of just coming at you with question after question, but I think it's because we're deeply curious about these, and it's very important to our community. Greg is asking, do you have any thoughts on housing first strategies as a mean to assist with treatment?
Well, I mean, we have so again, we're gonna open this up a bit. So we have a twofold housing problem in Canada that we like to combine and talk about in sound bites and politics and nothing more. So let's look at the twofold. One, we have an affordability crisis for our middle class and those who are struggling to afford a down payment. And there's more red tape to build a house than should possibly be there. But that's something that I don't really bother too much with. Like, blocking Airbnbs isn't going to fix the problem we have for the unsheltered living on our streets, suffering with mental illness, addiction, chronic pain, brain injuries. They don't really care about whether somebody's renting out their basement for an Airbnb. Housing first is important, but I would say the majority of people who are going to benefit from housing first are those people that need a hand up. They're the family that couldn't afford their rent. This is that need for low income housing, and the access to low income housing throughout this country is ridiculous. I have people, waiting months and months and years to get into low income housing. Horrific. Supportive housing is what I would put before housing first. Supportive housing is about housing first with wraparound services, mental health services, addiction services, health services, primary care, all of it wrapped around and intensified together. We are seeing, and I showed you the graph of where people are dying in areas that have incorporated housing first. I can talk about 3 different areas. We can talk about New York. We saw around 70% of acute overdoses that led to deaths were happening in some of our housing first areas. And that's because there wasn't any access to all the wraparound services. Saw the same thing in San Francisco. What's interesting is that we did not see that. And I can't remember if it was Austin or Houston. And so I was fortunate enough to be in Oregon working on fixing some of their policies with an international panel. And Anna Rausch was there, who's the Housing First legend down in Texas. And they were cleaning, and this sounds stigmatizing when I say cleaning up encampments. They were closing encampments and getting people housing. And their success rates were in the 80%. And I'm like, how is that possible? How is every other jurisdiction failing And you guys are succeeding at this. So we got into a good conversation. Well, it turns out they had much less fentanyl than what we see elsewhere, and that heroin was still quite prominent because the drug gangs that led things there were from Mexico, where heroin was being imported in, and it was the major part of the drug gangs area. And I was like, well, that is anybody who says that fentanyl didn't change the game, it changed the game tremendously. It is a game changer for all of us. So that was one thing that was vastly different. The other part is that same gang was running crack cocaine and real cocaine, not methamphetamine. So their substances were vastly different, which was shocking to hear that. I didn't even know that that could really actually exist. So I think that, and this is just hearsay and me talking to another person, but I think that we should really look at supportive and intensive supportive housing. We got to start looking at even more than that. If an individual has a severe brain injury, and you and I couldn't function day to day with that, how do we expect them to function just by putting a roof over their head? And in some cases, some individuals may need a step up. They may need intensive supportive housing. It's going to be a sad thing to start seeing our long-term care facilities start filling up with individuals with brain injuries who are living without the capacity to make good decisions. So, we may start needing to look at larger centers, care institutions to support these individuals. But I think it's a spectrum. It could be as little as housing first for the person that needs a hand up with low income housing, all the way to intensive supportive communities and housing programs.
Yeah.
Yeah. Oh, sorry. Go ahead, Robert.
Well, I was just gonna ask CSP, any other questions? Live questions? Number at the table, you can probably see on the screen.
So CSP, you'll have to unmute yourself if you'd like to ask a question. That might take a little bit of technological fandangling down there. That isn't easy. You could also just like wave at us or jump up and down.
I have a question for you, Rob.
Go ahead.
Do you think there's room for optimism for treatment options? I say this probably with, say, rehab in mind, where there are very few options besides, you have the 12-step or CBT down in Claresholm, I think. But is it? I see, what your organization is offering is. Do you see a proliferation of choice on the horizon for the suffering?
I'd like to think so. I think that, look, there's stigma around AA and the 12 steps. Good, bad, or indifferent. There is AA for atheists. There's AA for basically any identified group out there. And people, well, I don't like the big book, and I often have a good discussion with them. You know what is great about having 12 steps is that when you finish treatment, you have something to do. You have an algorithm, a process to follow. Now, there's still going to be some people that don't want that. So here's our biggest weakness that I think that we're going to struggle with is I go to treatment, then what? This is where we talked about that recovery housing. This is some of the great work that we're seeing with the therapeutic living units, which are basically Alberta is under quiet sheet is revamping all of our provincial jails into therapeutic living units or basically residential treatment centers. I got to tour the first floor that was done in Red Deer. Remarkable, talking to the individuals in the program. So the first 12 spots of the 400 inmates, like 200 of them applied for those 12 spots. So don't tell me people don't want help and don't want treatment. And what was awesome was talking to the correctional services and asking, what did you find with this? And the answer of, for the first time in my life, I feel like I'm actually helping people, not just maintaining order. I'm actually doing something that's going to change people's lives. Like, how awesome is that? Rehabilitation instead of incarceration. And the cool part is, and they're doing this in Lethbridge now, is and Fort Saskatchewan, they're going to transition all of these jails into therapeutic living units. And the cool part is then the transition of going from a therapeutic living unit right into one of our recovery centers where you get to stay another year. And so now you're up to 3 years of treatment. And in that time, in that year afterwards, a couple of months, you get into kind of stage 3 of treatment, stage 4, you get to start working in the community, not working at the center, working in the community. If you're working on the oil rigs, you get to go to the oil rigs. If you're working wherever you're working and staying there for free and building up capital and income so that you can transition back into the community. I think this is going to be a really interesting process to watch, really fascinating, but I think that's our biggest issue that we have is we take people, we put them into treatment, we take them out of treatment, and then we say, good luck.
Yeah.
We're not treating the underlying root. We're not treating the mental illness. We're not treating some of the reasons. We're not treating the intergenerational trauma. We're not treating all the community, and we're not celebrating recovery like we do celebrating recovery from cancer. And we really need to shift that mentality.
Thanks. Anything from CSP? Oh, yes, we do.
You got their hand up. Yep.
Yeah.
Can everybody hear me?
Yeah.
Yes.
Yes. Oh,
Yeah.
okay. Okay. We've overcome our technological mountain. Hi, Rob. It's Mara, and I just want
Hi.
to say thank you. Thank you so much for speaking with all of us today, and everyone for logging in and all of the questions. I think from our group, there's like 12 of us in the room, and I think we have filtered all our questions through Robert and Tracy. So I'm looking at everyone. I don't think we have anything else, but we just want to express our appreciation.
Thank you, Mara. I really appreciate that.
Well, thank you for the time that you've given us. I'll let Robert really close us off. But I know in this room, you've got our brains going.
Yay, that's the whole point. There's no black and white. It's a dialectic. There's many truths, and we've got to find the answer that incorporates all of them. And there is no, it's this way, or it's only that way, or it's only this way. That's for politicians, not for treatment providers. The other part I'd like to say is when I was kind of getting into this world, I often advocated we needed free on-demand treatment that was publicly funded. And I got pushback from mentors, from colleagues that the system can never do that. It can never afford it. We can never take care of those people. I'd like to call that a bunch of garbage. It takes political will. So imagine if we said that about cancer. Oh, there's too many people with cancer, and there's a lot of people that are going to end up with cancer. There's too many people with cancer to treat everyone. We're just not going to do it. Or we're going to allow private institutions to set up their own wonky cancer programs. And we'll just let anyone do whatever they want. We would never accept that as a society. It is shocking to me that former leaders, experts were saying this, that we need the private world to do this. We should not have to say that. What we need is political will. And what we need is the acceptance that addiction and mental illness are equal to heart disease and cancer. That a young Indigenous male who needs help is the same as a white old man. And that is what we need to all accept, not accept that we'll never get there. And we need everyone else to come in, even if they're shady and slimy and doing whatever private weird crap that they're doing. We don't need them. We need political will, and we need a good universal system that actually cares for everyone. So that's how I would like to leave it. And again, a real honor to be here with all of you, and thank you so much.